Welcome everyone who has joined us so far. We're just going to give another 2 minutes to let people log in, and then I'll introduce Dr. Roeland and we'll get started. Okay, so I think we're growing quorum here. So I want to welcome everybody today to our second Cancer Cachexia Society seminar series. These are occurring on Zoom virtually monthly. We will take a break for the holiday next month, and then we will resume in January, where Dr. Marco Sandri will talk on neuromuscular junction disruption in cancer cachexia. That will be second week of January. We will put out info, emails, Twitter, as we get closer to the date when we have exact date and time for that next series. Today, I'm very excited to introduce Dr. Eric Roeland from Mass General Hospital Cancer Center. Dr. Roeland's a dual trained oncologist and palliative care doc, and his research focuses on improving cancer-related symptoms, including cachexia, and trying to expand pharmacologic options for patients. And he's also the co-chair of ASCO's supportive care and cachexia nutrition guidelines. And so again, like to welcome you, Dr. Roeland, and get started whenever you're ready.
Great. Thank you so much, Richard. And I recognize a lot of familiar faces out there. So my hope is that you guys just interrupt me, and this is more of a conversation and less than a presentation. So when I was asked, first of all, I was honored to be asked by this group. And I'm so proud of the organizers for getting this lecture series started, just so that we have a place where we can convene and discuss and move things forward. But I think a very important first step, of course, is to see where we've been and understand the data of the clinical trials out there, so that we don't make the same mistakes, and that we can get some of this incredible science moving forward. So, first of all, happy Veterans Day to everyone. And if you know a veteran, be sure you call them and let them know that we're all thinking about them. You know, this slide from Dr. Barakos and colleagues at Nature Review, you know, is trying to simplify a very, very complicated metabolic syndrome. And, you know, part of the complexity and the difficulty that we have in creating and defining clear endpoints in clinical trials is just this. It is a very complicated syndrome. And when we try to take bites of this and move forward, it turns out to be pretty more complicated than we can imagine. And we've also had a rise of more and more companies interested in evaluating novel drugs in this setting. Many of them are familiar to you all. And they're trying to take out these bites in this metabolic syndrome to try to improve how we can control this syndrome. So as I go through this, what I'd really like you to focus on, and hopefully you can take some notes, and I know all of our attention span is pretty limited, I just would like you to ask yourself, how would you design the optimal clinical trial in Cancer Cachexia? And I'm sure you have some thoughts on this, even if you're at the bench. But if you're at the bedside, you also have some clinical pearls. And I just want you to think about endpoints, which patient populations, and then, of course, regulatory approval hurdles that we've been dealing with. And for those of you unfamiliar with the guidelines that were recently published, I'm going to review some of the data from that, and that is available through JCO. So you take this very complicated metabolic syndrome, and then we think to ourselves, how do we define it? And this sounds like the most simple question, but what I've learned is that this is probably the most difficult, and this is probably one of the biggest barriers that we have in our field. As a clinical researcher, I look at clinical endpoints, and the things that matter to me, patients and caregivers, is loss of appetite, obviously weight loss, skeletal muscle loss and how that leads to functional impairment, treatment-related toxicity, which we have good data to support, quality of life. Don't forget caregiver distress, who oftentimes are as distressed, if not more, than patients, and of course, reduced survival. And then I think we all kind of turn to the consensus guidelines from 2011, and I know Dr. Barakos is working on getting another group together to reevaluate this consensus definition. But you can see the 3 stages with a focus on weight loss, some beginning loss of appetite. We're seeing inclusion of muscle loss, reduced food intake, and then functional status. But the holy grail, of course, would be to intervene early, to identify and intervene early, rather than what unfortunately is happening in most of our trials, where we're either focusing on refractory cachexia or cachexia itself. So we have a very wordy definition in our guidelines, trying to capture all these clinical endpoints. We describe it as a multifactorial syndrome characterized by loss of appetite, weight, and skeletal muscle, leading to fatigue, functional impairment, increased treatment-related toxicity, poor quality of life, and reduced survival. And we really had to focus on endpoints that we could capture from the data. And so the 5 endpoints that we looked at were anorexia, weight loss, physical function, quality of life, and lean body mass. And specifically, we looked at nutritional interventions, pharmacologic interventions, other, which really is exercise. And then we asked ourselves, do we have any data to support that these actually improve clinical outcomes? And I have had many people ask, what about this trial or what about that trial? And I think it's important for us to just kind of take a step back and see what we did. So we did a systematic review. We looked primarily at randomized controlled trials or systematic reviews all the way back to 1966 to 2019. And there had to be at least 20 patients. So unfortunately, the data is filled with all of these small studies. But we were able to find 36 studies, including 20 systematic reviews and 13 randomized controlled trials. And when we look at food or nutritional interventions, unfortunately, the strength of the evidence for all these is low. But as a group, we felt like dietary counseling had more benefit than risk or harm. But you know, sadly, despite people that have really dedicated their careers to trying to improve this, and we have the ASPEN guidelines, the ESPEN guidelines, the data isn't that great. We also looked at routine parenteral and enteral nutrition. And again, in this setting, it's actually moderately against omega-3 fatty acid, vitamins, minerals, and supplements. Again, you can kind of see this. And then exercise. And again, I think most of us as clinicians would say, you know, please exercise, keep moving, low to moderate resistance exercise. But again, the strength of evidence that's currently out there is pretty low. So when we look at pharmacologic interventions, the best that we have at this time includes progesterone analogs, primarily majestrol acetate, and then corticosteroids. And Roeland, I will review with you, and then briefly describe some of these others. But I most frequently am asked about anamorelin and cannabinoids, and I'm getting more questions about olanzapine. So to take us a step back here to Dr. Chuck Mortel in 1974, he did the first study looking at dexamethasone. And of course, we use dexamethasone because it is a fluorinated corticosteroid, which gives it a 72-hour biologic half-life, which always has just boggled my mind about some of our dosing strategies within oncology about Q6-hour, Q4-hour dosing. But in this study of 116 patients, he looked at placebo versus dex and looked at, and this is notable, patient-reported changes in appetite, strength, and physical performance, and just kept this simple on a scale of 0 to 100. And what they found was no difference in survival, but did find a statistical significance in appetite. And so here we have a very simple study looking at, you know, not a huge patient population, where he showed looking at, you know, patient reported. So this is what patients experience and what they tell us. And you know, that's the data that we have going all the way back to 1974. When we look at majestrol acetate, you know, there is great data to support its use in improved appetite, weight gain, and quality of life. And again, I'm kind of highlighting some things here. This is what patients tell us. This is what patients tell us. However, especially as a GI oncologist, I really worry about things like thromboembolism. You know, that increased relative risk is no joke. Edema, somewhat, and I can't find the data on adrenal insufficiency, but I often find that patients are on majestrol acetate who get admitted to the hospital and have hypotension. People forget that this may be one of the causes of that. And just an important thing for everyone to think about, because they might need pulse dose steroids at that time. And then we look at dronabinol. You know, cannabis is a really complicated situation for study in our country. And as more and more states approve its use, both in the medical and recreational setting, it becomes more and more complicated in how we're going to study this. But when we look at artificial THC, Immunogestoy through CLGB, or now the Alliance, looked at a sizable patient population of 469 that were randomized to magistral acetate with placebo, dronabinol plus placebo, or magistral acetate and dronabinol. And again, we see that here is appetite improvement through a patient-reported outcome, and here we have in the black is magistral acetate, the combination arm, and dronabinol. And so you can see an improvement in appetite, weight gain, but I think more importantly, patient-reported weight gain. And when we look at quality of life, again, using a scale that has been used in other modern cancer cachexia trials, where we recognize a difference here. So in these complicated times, I often reflect on some advice my grandfather gave me, and that was the greatest sign of intelligence is to keep things simple. And with a very complicated syndrome like we have here, I really appreciate now the intelligent design and simplicity of these things, relying on patients to tell us how they're feeling. And it's important for us all to recognize that magistral acetate and dronabinol do increase weight gain, but it's primarily adipose tissue and fluid, not muscle. And as someone who's really interested in body composition changes, this, I struggle with this a little bit in that, we ideally want people to increase their lean body mass, primarily skeletal muscle. But at the same time, as a patient and caregiver, maybe this weight gain and improvement in appetite is really all that's important to them as they sit around the dinner table. So I think this is also something for us as a group to really consider, especially since the FDA historically has required an improvement in lean body mass as a regulatory endpoint. Our colleague, Rudy Navari, also looked at the combination of magistral acetate and olanzapine in a small group of folks. When we see, so we have 4 weeks and 8 weeks is the darker color here, and magistral acetate plus olanzapine. And so we do see an improvement in appetite, quality of life, and weight gain with this combination, but we have not studied olanzapine as a single agent. This is over 8 weeks. And then probably the most exciting study to date is the Romana 1 and 2 trials sponsored by Helsin, and this was the evaluation of Roeland versus placebo in advanced non-small cell lung cancer. And, this was a very exciting study in a big group of patients. And again, we see an improvement in lean body mass in a patient population in which that doesn't happen. And then, unfortunately, this functional measure was negative, and that, of course, led to it not being approved. But let's take a look also at some of these other important things, such as the mean anorexia cachexia score, which was significant. And so I think there are some little pearls throughout all of these studies that we need to try to capture and use as we look forward to the future. And so sadly, there are no FDA-approved drugs for cancer cachexia, and I think you all know that, but our colleagues don't. And I often hear them complaining about why we have to do prior authorizations for such drugs as dronabinol, and this is it. This is why. Of course, dronabinol was approved in the 80s for wasting associated with advanced HIV. And, once you get a approval in one indication, companies really don't want to keep going after other indications. and they're just hoping that folks use it off-label, which we have. The study of Roeland is not done. And in fact, there are studies still occurring in Japan and in the U.S. And what I like about this is now we're thinking about a primary outcome that is a composite clinical response over a similar time frame of 8 weeks. But we're looking at both a change in body weight from baseline and an increase on a patient-reported anorexia symptom scale. And when we think about this even further, they're actually requiring that patients have involuntary weight loss, but also that they've had anorexia. So they have to have at least a measurable amount of anorexia to get on the study. And I don't know where things stand in terms of accrual, but if you want more information, it's available there on clinicaltrials.gov. So the future of Cancer Cachexia trials, in my opinion, it's really important that we identify patients early. And I think there's two ways to do that. The first would be, I think there's been a lot of attention on biomarkers, and those are usually blood-based biomarkers. We found a couple, especially, some of our trials, for example, the MABP1, which is the fully humanized monoclonal antibody to IL-1 alpha, actually required higher levels of circulating IL-1 alpha to get on the study. However, that didn't necessarily lead to improved outcomes that we saw in the trial. Other biomarkers that are evidence-based is looking at the neutrophil to lymphocyte ratio, or the Glasgow prognostic score, which is a combination of albumin and CRP, which is a poor man's marker of inflammation. This piece here is huge, and I think this is the opportunity for us to collaborate with our basic science colleagues, and we just like we are doing in oncology, we need to start with a biorepository of specimens where we can start evaluating this on a much more global scale. The other biomarker, of course, is body composition and looking at changes in skeletal muscle and fat along with the tumor. And so I think that is often forgotten that is a biomarker in itself. And then looking at patient-reported outcomes. So this is a much more inexpensive way to approach things, but ideally we would have patient-reported outcomes and blood-based or radiologic-based biomarkers that would enrich a patient population that in whom if we did intervene, we could see a more marked improvement. And this is what we need in our field. We need a win. I think that much like other areas within supportive oncology, the attention grows to that area or that symptom when new drugs are approved. And that can be exemplified by chemotherapy-induced nausea and vomiting in the 80s and 90s with 5-HT3 receptor antagonists and NK1 receptor antagonists. We can look at GCSF and Procrit. When there is a win, it is huge. It is not 5% of non-small cell lung cancer patients that are getting a specific drug, but rather a huge patient population. And we have to remind our industry colleagues that this is, in fact, a huge potential for them. The other thing we need is specific clinically relevant endpoints. And I think that we have strayed a little bit in trying to look at functional endpoints in a patient population in which exercise and doing clinical evaluations of physical capacity is pretty difficult to do, and another barrier for patients to come on study. And for that reason, I feel like looking specifically at anorexia and patient-reported outcomes using validated scales is really where we should go in terms of keeping things simple and learning from the past. We also need clarification around approvable endpoints with regulatory agencies. And all of us, when we engage with them, I think what we're learning is that patient-reported outcomes are now seen as their own science. And when we are thinking about using validated scales, we need to make sure that those scales have been approved in the patient population we are considering, and the minimal clinical difference is something that we can achieve in our study. And then I think the distant future includes multimodal interventions. Although this is a multimodal syndrome, I think that we have to validate each piece of our multimodal intervention and then look at it as a whole. However, there is the ongoing study in Canada and Europe called the MENAC study, MENAC, that is also the information available on clinicaltrials.gov if you want to learn more about that, combining a nonsteroidal anti-inflammatory, a nutritional supplement, and then light resistance exercise. Just taking a step back, this is a horrible article by this no-name researcher, but I had struggled so much in getting patients on this one clinical trial, and I was trying to figure out why that was. And so many patients weren't getting on the study because they hadn't lost enough weight. So I wanted to see if we had changed our inclusion criteria to a 5% muscle loss as measured on routine CT scans. If we excluded 17 patients because they had not lost enough weight to get on study. 7 of those would have been included if we had used muscle loss. And then we still have these patients in this 5 to 20% range. So we would have actually captured a much larger group of patients. And so I think that's something else that we should consider instead of just weight loss alone. And there is incredible energy now using artificial intelligence to actually make quantification of skeletal muscle and adipose tissue more automated. And I do see a future in which we are sitting at tumor board and not just getting the calipers out to measure the tumor size, but also looking at body composition as a prognostic marker. However, you have to ask yourself, if you were told that someone had lost X% of their skeletal muscle, how would that change the way that you treat the patient? And that, again, remains a big black box. So we would need to further identify how not only patients and caregivers, but how clinicians would respond to this type of information. And then selection of endpoints. I think it sounds easy with the patient-reported outcomes, but it's not always easy. And so you want to make sure that your mechanism of action of your drug is also aligned with the selected patient-reported outcome, that it is validated in your patient population that you're looking at specifically, and can you beat the minimal clinical significance? So those are some key characteristics for everyone to think about. So reflecting back to all of you, and hopefully you were taking some notes. If not, wake up. Here we go again. So what does your proposed clinical trial look like? Kind of looking at that evidence. What would you envision? Do you envision a advanced cancer population independent of histology? Are you looking at quality of life? Are you looking at anorexia? How do you measure these things? So I would really like to hear from others about their thoughts. I have also included my contact information here, and I would love to hear from any of you. Dr. Dunn?
Thank you. Thank you for that great and succinct talk, really giving us a good overview of the guidelines, kind of where we at. I was struck by the fact that there were 13 randomized clinical trials in the last 60 years, almost. And so clearly we need to do better. In terms of designing trials, we have some questions in the chat, and we certainly have time to get to them. But in terms of your first question about designing the trial, what does it look like? And I think I agree with you and many that multimodal interventions are going to be needed for a kind of a multi-pronged attack. But I have a question. I don't know if you can answer this, though, is in terms of drug approvals and the FDA, how does that complicate things if, let's say, you combine an MRLN with exercise, if you do get a positive trial and it does get, it does look like it works, how does that work with approval? Is it get approval blanket, or there needs to be a exercise prescription that goes with it, or a nutritional supplement that goes with it? I don't know if you can answer that question, but that's something that I wonder myself.
Yeah, and I'm open to hearing from others that are, much more attuned with the literature within nutrition and exercise. But I would say that I see steps in this process. I see a step validating a pharmacologic intervention. I see a step validating an exercise intervention, and I see a step validating a nutritional intervention before we can really combine them all, because we're struggling just trying to get a pharmacologic intervention out there, which we know, drug studies are easily implemented and disseminated in contrast to exercise and nutritional interventions. So I see this as separate and all equally important. But I don't see this being a multimodal intervention right out of the bat.
I have a comment to that, Eric. This is Jose Garcia.
Oh, thank you for jumping in. Yeah.
No problem. And first, thank you for putting all this together. This is really a great talk. And my comment to your question, and I don't actually have necessarily a better strategy, but one challenge with trying these different interventions separately is that oftentimes anabolic interventions depend on nutrition and exercise to be effective. And so if we want to validate, let's say, an orexigenic agent, but then there's no nutritional support and that patient is not eating, then that will make it actually less likely to work. Same thing is true with, for instance, activation of the androgen receptor. If you don't exercise, the chances of that inducing a meaningful change in function is much, much lower. So we have to realize the nuance that a lot of these interventions actually are not additive to each other necessarily, but they can potentiate each other. So that will be an argument for actually try them together and not separately.
Some synergism that we wouldn't see by studying them individually, and that is what you're saying.
Right.
If I could jump in, Richard,
yeah.
Just to piggyback off there, Dr. Garcia, I think one of the other risks of doing these unimodal trials is if we need synergy to support effectiveness, and studying them in isolation results in null effects, we risk making or not being able to make the decision to go to multimodal trials. We see analogous in our work in terms of creatine supplementation. It's been investigated in a few different populations in cancer as a standalone therapeutic, and pretty much null effects for the same reasons that Dr. Garcia mentioned, in that it really needs an anabolic stimulus along with it, with resistance training. And for me, from a meathead perspective, when I look at like the Romana and the enobosarm trials, seeing really meaningful changes in lean mass without changes in function. We've seen the opposite in our exercise trials, where we've been able to kind of fairly reliably change function, but not reliably change lean mass. So to my mind, that looks like the perfect synergy. And I think there's enough support on either end to, at least if trials like the MENAC exist, why not give it a go with pharmacological interventions in exercise?
Yeah, I agree with you.
happy-
I've seen the same thing in our exercise studies here, is a change in function, but, without, possibly meaningful changes in weight without doing some sort of nutritional or pharmacologic intervention with that.
I have a comment, Richard, if that's okay.
Yes, go ahead.
And again, Eric, excellent and provocative presentation. Thank you. Just to bring on Kieran's point, as one of the MENAC sort of PIs, we are of the belief that this multifactorial genesis of cancer cachexia is best tackled with a multimodal approach, but we await the results of the study to prove or disprove our findings. I guess one thing that springs to mind, you asked me, what does a proposed clinical trial look like? To me, it's fundamental, in the same way that as oncologists we stage the tumor, we need to stage the host. We need to stage our patients. And I'm not talking about TNM stage. I'm talking about, for example, performance status or inflammatory status. So we need to stage the host the same way we stage the tumor. And work that we've been involved with the Glasgow prognostic score, which you kindly mentioned, Eric, has demonstrated that the baseline inflammatory status influences survival, it influences quality of life, it influences response to anti-cancer therapy, and we did a post hoc analysis of ROMANA 1 and ROMANA 2, and essentially, when we did the pooled analysis, those patients with higher levels of systemic inflammation had a greater response to anamorelin than those who did not, which would fit because anamorelin has some effects on interleukin 6. So I think stratifying the patients before they enter the trial is important in terms of inflammatory status, but also to try and stage the host, the same way we stage the tumor. Any comments, Eric?
Yeah, Barry, I think that's fascinating, and it aligns kind of what I was describing with patient-reported outcomes, in that you have patients who are reporting some amount of symptoms, right, before you study them, and you can measure change over time. I love the simplicity of the Glasgow prognostic score. I think that here's a great opportunity for us to, even in an observational way, measure this across different cancer types. As far as staging, that would be phenomenal, and I would be happy to collaborate with others in terms of how you would stage that, which of course would take a huge number of patients, which I think through a collaborative research project would be possible.
Yes.
Yeah, and the thing I think many times non-oncologists or bench researchers may not be aware of is that functional status from the oncology standpoint is actually very, very poorly done and very poorly documented. In fact, I was just reading in the October issue of JAMA Oncology, there was an artificial intelligence algorithm that was going through all of the medical records of GI cancer patients at Massachusetts General Hospital. And sadly, only half of the patients even had a functional status even mentioned in their progress note. So the untold truth about ECOG performance status is, if the treating clinician wants the patient on a study, they are going to be an ECOG 0 to 1. Right. If the treating oncologist does not want them on study, they're going to be a 2 or 3. There's no assessment per se. So I find that incredibly challenging. And, folks interested in exercise, if we could find a very simple screening method within the clinic, and I mean simple. For example, I had a patient who yesterday I was really worried about being too weak, and I just asked him to walk around the clinic before we even discussed treatment. I don't think any of my colleagues do that. So I would really need your guys' help on something like that, because we can't have people doing stair climbs and timed up and goes just because oncologists are just not going to do it. So I think that is another part of the staging. So we have the inflammation, we have the symptoms, and now we have some kind of screening for functional status. And I would really love to hear people's thoughts on that.
Dr. Zimmers had asked in the chat about, a quantitative staging, taking all of that into account with the next set of cachexia consensus definitions. I think that's something that is sorely needed and will likely be a topic of discussion. I think in terms of how we stage it, and whether we use certain functional or physical performance measures, which sometimes are hard to do in the clinic, I think something that is talked about frequently are patient-reported outcomes. And so one of the questions, I believe, is from Dr. Marks, who said that I've seen a strong movement at the FDA toward allowing measures of daily activity or measures of quality of life as approvable endpoints. Is this your view as well? And to piggyback on that, kind of just this whole theme of PROs, with so many different scales and different tests and things that are used in Europe versus the US, how do we come together as a community and come up with a standard patient-reported outcomes that we can agree on, that can be tested, that can be validated? And I think that's really what we need to move things forward.
Could I comment, Richard?
Yes, go ahead.
An excellent point again. It strikes me, how can we expect the regulators to have a consensus when we as a cachexia community do not agree what the correct way is to measure physical function or body composition or appetite or weight loss versus BMI, etc. So I think there's a need for two things. One is a mandatory data set for all cachexia clinical trials, the same way they have, for example, the compact recommendations for pancreatic cancer. We need that. And then we need a consensus statement or agreement from based on evidence where it exists on what are meaningful measures, because the regulators don't know, because we don't know. We don't agree.
Yeah, absolutely, Barry. I think that's the problem, is we're all pointing fingers at one another and not coming to a consensus here. I keep going back to chemotherapy-induced nausea and vomiting, and the validated scales that have been used, or the endpoints have been used for decades. Complete response. That means you haven't vomited and you haven't used a breakthrough nausea medicine. I mean, they're pretty simple, but again, I think that's where we need to go. I think we need to stay away from really complex things. I think that the scales, the FAACT, from the FACET group, which is just a subscale of the FACT-G, to me is one of those, and I've selected that in that I wanted to be able to compare it to the largest study that's used that, which is the Roeland study. But we don't know if that's true across all different histology types. And the other piece of that is I wonder if really the more measurable and easier endpoint to just get a base hit would be anorexia. Like, just keep it simple, just be anorexia and see if we get somewhere. But with reference to Dr. Marks and his comments about patient-reported outcomes, I have absolutely seen a transition where the FDA now considers this a science and are pushing back on the scale selection, the validation within the same patient population, and of course that minimally clinically significant difference, which is a big challenge for industry and researchers, because you may not have that scale that's been validated in the selected patient population. And so we now have those scales in non-small cell lung cancer, but as any clinical oncologist will tell you, that is a very competitive space right now to be in, where, you know, there are so many treatment trials. A supportive care trial is going to be very, very difficult and costly to get done. So I am really focused right now on patient-reported outcomes. And that has been a big transition for me, because I was really more focused on functional outcomes, but I'm realizing just how difficult it is for us to incorporate that in the clinical environment and within oncology. I'd like to hear other clinical oncologists to hear what their experience is in the clinic, but right now I get 30 minutes for follow-ups. I get an hour for news. We have to consent for chemo. We have to talk about the risk benefits. We have to look at all the side effects. We have to look at social support, advanced care planning. I need to make sure I document all these things, and then add clinical trials on top of that. It's a lot. So I hear the purists out there who want these other pieces to capture all aspects of anorexia cachexia, where I think I'm not sitting down to eat the whole meal. I just would like to eat just one bite and see where we go.
Yeah, time is certainly a pressure for all clinicians. You know, coming up with ways that we could capture some of this data and, you know, not have it as part of the doctor's visit, whether it's a set of PROs that get mailed to patients prior to their visit, or get put on my chart for those that use electronic health record, or gets administered, you know, by the nurse before the patient and before the physician enters the room. I think we need to, you know, start thinking about this as better ways, you know, better ways to really capture physical performance tests. They take time. And they take resources and they take space. You know, the hand grip can be done. We've talked about that at many of our meetings. But you know, the more that gets studied, the less people are excited about using that as an endpoint. There's an interesting question I want to bring up here. I want to see what your thought is, Eric. From a breast oncologist in our audience, Dr. Ballinger. Does the impact of these interventions need to take into account the cause of the cachexia? In some circumstances, it's the disease. Sometimes it's the therapy. We know chemotherapy can induce muscle wasting, particularly platinum chemotherapies. And hormone deprivation. We know that certain hormonal treatments can do this as well. How does this impact how we think about interventions, you know, the cause? I don't know if we're there yet in terms of understanding and having adequate treatments to fully target that yet, but that is where the field needs to go.
You know, again, an excellent question. And I wish we were at a point where we could identify a clear mechanism for each patient and their cancer type. I think a different approach to that would be to just incorporate progression-free survival and measure RECIST criteria of tumor measurements and include that in our Cancer Cachexia trials, because one of the central dogmas within cancer care is you treat Cancer Cachexia by treating the cancer. And if we can show that that is either part of why we are improving muscle mass or independent, I think it needs to be studied. And when you look at all of our studies looking at body composition, they all include body composition, but they do not include RECIST criteria. And that's because of cost and involving radiologists. So the standard approach within oncology is to do RECIST, but not do body composition analysis. So an alternative approach to this, which has not been discussed, is not to have clinical trials dedicated to Cancer Cachexia, but rather embedded within other trials as secondary endpoints. So we are capturing prospective data as a secondary endpoint. And the opportunities there would be within our cooperative groups. But again, we would need our oncologists to be on board with that. I think that's possible, especially since now patient-reported outcomes are almost required as a secondary endpoint in our interventional studies, but we have not been looking at Cancer Cachexia specifically.
One other question that I actually had the same question was if an inclusion, so this is referencing the most recent ongoing NMRL trial in the US. And the question is, if an inclusion criteria of BMI of 20, this is not likely to be early cachexia and more likely refractory cachexia. So this study was open in our medical center, and I know it wasn't accruing very well. And one of the reasons why was because the BMI was so low. We know based on that, infamous paper by Dr. Martin and JCO a few years ago, that many of our cancer patients in Western world are obese and have actually normal or elevated BMI and can still have cachexia, this phenomenon of sarcopenic obesity. So what happens if this trial that shows an improvement with a low BMI less than 20? What does that mean for the rest of patients that may have cachexia with a normal BMI?
It is a huge limitation of the approach. I think you can clearly hear me say patient-reported outcomes over and over again because of these very things. These composite clinical endpoints are a compromise, right? It's a compromise between something that's considered measurable versus something that's patient-reported. But now we're in a time where patient reports are measurable and a science. So I share the same concerns. I mean, a BMI of less than 20 is not okay, and of course is refractory cachexia, and a very excellent point.
I'm just going to add to that, if I may. It just strikes me as odd that, post hoc analysis on Romana 1 and 2 demonstrated that those inflamed were most likely to respond. And a similar phenomenon was shown with the MAP-P1 studies. The certain patients groups of where these drugs are more likely to work. So it would seem, foolhardy to do a trial and not, optimize the patient group you're recruiting to with these studies. And I think that's a huge area for us is how we really characterize our patient population. And cachexia is probably one of many syndromes that exist, and we still don't really know that.
Yeah, absolutely agree.
I think he left, but maybe we could follow up with him offline. But Joseph McCollum had a couple of questions. One was, evidence of mirtazapine in the use of cancer cachexia, whether there's trials or anecdotal evidence, and had a question about off-label or compassionate use anamorelin. Has that been able to be acquired by anybody? Did you guys look at
I can take on the
mirtazapine in your guidelines?
Yeah, we did, and of course the data was pretty bad. I think the use of mirtazapine most likely is equivalent to a placebo effect. The doses used are 7.5 milligrams to 15 milligrams. People say they're also treating depression at the same time. That is not true. Those doses are not effective for improving mood, and any psychiatrist would tell you that. I think that we can't underestimate the effect of a placebo, and I'm saying that in fun. I know people do give mirtazapine, but I really don't think you're actually treating the patient in that setting. You're treating more the caregiver and yourself.
Right. Yeah, and it seems like I've not even sought to, see if I could acquire an MRL, and I wouldn't recommend anyone do that without any, further confirmation of the data. Although it does in multiple studies now. It clearly improves lean mass and weight and appetite, and hopefully we'll get some sort of approval soon. So, any last comments or questions as we're approaching the 1 o'clock hour? This is a great discussion. I really want to thank Dr. Roeland for being part of this. This was perfect in terms of giving us food for thought for discussion, and a really great discussion. I'm glad many people were able to jump in. And we really look forward to continuing this series and having a robust engagement, which we really need. And so I really enjoyed this. I'm really happy with the turnout.
Yeah, I just can't say enough. I'm just scrolling through all the participants, and I know we're losing some with the time, but man, this is great. And this is exactly what we need. We need disagreement, we need conversation, but I think most importantly is we need to build a research consortium focused on this so that we can build the evidence and move things forward. And I know there's people on this call that know how to get that kind of grant money to move things forward. And I hope that all of you would be interested and would like to participate in something like that.
Yeah, it's, I'll plug for our society, but also for our meeting. I mean, our Cancer Cachexia meetings are a great place for, and hopefully we'll be able to resume in person. We'll see. But next meeting will be in August of 2021. It's really a great opportunity for people to come together and collaborate along with these sessions. I've gotten, just interacting with some of you. So I encourage you all to continue coming to the series, consider joining, and consider marking down the date at the end of August in your calendar for our meeting.
Thank you all.
All right, everyone, take care. Thank you.
Bye-bye.